as I say, I hope what I tell you isn't too much different to what you heard this morning. I'll get used to this and I'll try and push the buttons. Okay, so I haven't done the full title in your agenda. So I'm going to talk about adjuvant therapy and hopefully answer some of the questions. This is histology, large gastric cyst, and this is Birmingham, that's the new Queen Elizabeth Hospital. And gone long already. And I think we are just about somewhere. I think that is some blue, so we must be next door. So the hospital, the QE was opened about 3 or 4 years ago, and I gave this talk about 5 years ago. There was no QE, and the information available on adjuvant therapy was somewhat different. So it went from being who should we give it to and why, to should patients be offered adjuvant therapy. And that was, I think, in 2009. So just very quickly, for those who are maybe newer to the GIST family than others, Imtinib, GIST weren't, you probably all know all this, but just to put it into perspective, GIST weren't described into the 1980s as a specific entity. And they are generally considered to be chemo-resistant and radio-resistant. And there wasn't much to offer patients with advanced disease. And then in 2001 at ASCO, which is a huge oncology meeting, there were about 100,000 delegates in the American Society of Clinical Oncology. In the main session, which has the latest breast cancer, the latest bowel cancer trials, they had 2 out of 5 sessions on GIST and this drug, ST1571. And it is one of the few things, genuinely in medicine, that was absolutely groundbreaking and a huge quantum leap forward in the management for patients. And it was all based on this thing called c-KIT, which I think Philippe Tania spoke to you about in a lot more detail than I could. And this Imtinib had been introduced for chronic myeloid leukemia, which we've known when I was at medical school had something called the Philadelphia chromosome. And as that developed over the years, it was realized this was a growth promoter for the tumor, and Imtinib was developed to block the promoter of CML. And it was recognized that the c-KIT was very similar to the can't remember what it's called now, but the Philadelphia chromosome. And so they just thought, maybe Imtinib will work in these patients. And the first report was 2001. There were no clinical studies in GIST, and it was a lady in Finland who had extensive disease. She had all sorts of treatment, and just as proof of concept, they started on Imtinib. And this is a PET scan. It's easier to walk. For those who've never seen PET scans, it's a radioactive injection taken up by tumours, including GIST. So all this just shows hot radioactivity. And within a month, this is bladder, which contains urine, which excreted, it had gone. I remember someone saying we were a bit concerned we got the wrong patient. But this is a CT scan, and that's 4 months. And again, this huge mass here melted, and that was the first patient ever to receive Imtinib without any trial, any clinical trial in GIST. So we knew it worked well in advanced disease. It was licensed in 2002 and approved by NICE in 2004 without any clinical phase 3 data. I think it was, and perhaps still is, the first and perhaps the only drug to be licensed on phase 2 data. So what is adjuvant therapy? Well, it's treatment given after definitive treatment to reduce the chance of the disease coming back. And adjuvant chemotherapy for breast cancer has been allowed, well, tamoxifen, then chemo has been around for 30 years, bowel cancer at least 20 years. Now the advantages are, it may improve your chance of being cured. It may stop the disease coming back, or it may, if not stop it, delay it. And we'll talk about whether that's a good endpoint later. The disadvantages are a lot of patients get it who don't need it because we don't know. It's a group of patients who appear to have been cured, but we know some of them, it will come back. And so a lot of patients will have this treatment who will never need it. Unfortunately, it doesn't work with everybody, so there'll be a group of patients who have the treatment for absolutely no benefit. And you've got to weigh up against that the toxicity and the financial cost. And certainly for bowel cancer, we talk about a 5 to 7% survival benefit for chemotherapy. So that means that you're giving it maybe 1 in 15 people are gaining a benefit, and the other 14 are getting no benefit at all. And it's a balance. So we know that for the certain high-risk GIST patients, and overall, I think this is probably historical data because we are diagnosing smaller and smaller tumours, but this is historical data. The classic survival is about 54% at 5 years. And we knew if you had a tumour over 10 centimetres, then it fell to 38%. And so the question was, as it's so effective in advanced disease, may it reduce the recurrence after surgery? Now, you may remember this chap with his famous quote, there are known knowns, the things we know. There are the known unknowns, I'll get this wrong, the known unknowns, which are the things we know we don't know. And then there's the unknown unknowns, which are the things we don't know we don't know. I think that was... So what are the unknowns? Well, for the sake of time, I'll just... which patients are most likely to benefit? Now, you might say, well, give it to every patient because everybody's at some risk. But then, do you give it to patients who are at 50% risk, or 80% risk, or 10% risk? Because where does the balance hang in terms of toxicity? Which patients may benefit? What treatment? And should it be one treatment fits all? And we'll talk about whether, for example, wild type with Exon 9 deletions benefit from Imtinib. How long should patients be on treatment for? And as I say, is the time, if you can lengthen the time for the tumour coming back again, but don't increase your chance of cure, or even increase your overall survival, is that a benefit to a patient? And you can answer that better than I can. Okay, so there's a number of phase 2 trials, early work. There was the American College of Surgeons Oncology Group, as they call it, the Z9000, which was entered at ASCO 2005-2008. There was a Chinese study entered in 2007, which has never been updated, and there was a Scandinavian study published in the British Journal of Cancer in 2007. And we now have a number of randomized phase 3 trials. There was the Z2009, the Z9001. There was a Scandinavian study, which is now being published, and we're still awaiting the data, or any mature data, from the EORT 62024. But there was some early data in 2013 in ASCO. So this was a small trial in China. They were high-risk CD117 positive GISTs, over 5 centimetres, over 5 mitoses per high-power field. Patients started on Imtinib 400 milligram daily, primary endpoint relapse or metastases. And the recurrence-free survival at 1 year was 96%, which, based on historical data, was thought to be exceptionally good. So certainly the conclusion of this was Imtinib seemed to delay or potentially delay the recurrence of GIST. So this was, again, just a phase 2 study. They just took 23 consecutive patients. They received Imtinib for 1 year. Don't worry about that. And this was the survival compared to historical controls. Or not the survival, but the risk of recurrence compared to historical controls. So you can see the top graph, very few patients developed recurrence over the 108 months, which I can't do the maths, but it's a few years, compared to historic. Now we know as things change, we know as medicine moves on, whenever you compare a modern cohort to a historical cohort, you tend to see an improvement in survival. But this was considered more than just historical and evolution of medicine. And then there was the American, the Z9000, and this took high-risk GISTs over 10 centimetres, or ruptured or multifocal, c-KIT positive, complete resection, and they had Imtinib for 12 months. And the primary endpoint was survival. So this was the recurrence-free survival. in terms of, sorry. And this was the overall survival up to 3 years. And again, based on historical data, this was thought to be very positive and worth looking at further. So they moved on to a phase 3 trial, randomized double-blind study. So patients got either placebo or they got Imtinib. They had to be CKIP positive GIST over 3 centimeters, which wasn't very big. Had to be completely resected, no Imtinib, within 70 days. Now, the primary objective here was the recurrence-free survival, and I think by the time this was published, everybody knew what it would show. But of course, it was commenced in a time in the early 2000s when we did not know as much as we knew by the time it was published. Secondly, objective overall survival. And this was the schema. So patients started on placebo or Imtinib for 1 year. If they got recurrence on placebo, they went on to Imtinib 400. And if they got recurrence on Imtinib 400, they went up to 800. And they were followed up for 10 years. Don't worry about all the data in this slide, but out of the number of patients, only a small percentage, or relatively small percentage, had large tumours. And a significant proportion, about 80% of patients, didn't even complete Imtinib for 12 months because of toxicity. Now, this was first presented at ASCO, and then it was published in 2008. And I'm just going to show the comparative data. So this was the early data, and this was for tumours 3 to 6 centimetres diameter. And again, what you can see is the orangey sort of colour line at the top, and was Imtinib, and the green line is placebo. So this shows that in the first 2 years, there's a difference in terms of recurrence of disease. So placebo is delaying recurrence, but by the time you get to 3 years, the same number of patients in each group has recurred. And in fact, this is the updated data, and the curves are very similar. This is the 3 to 6 centimetre tumours, very small numbers, so the lines appear to be, the Imtinib seem to be doing a lot worse, but that's just very small numbers at that time. And again, what actually happens is by the time you get to 3 years, the curves come together. And this was the tumour 6 to 10 centimetres. I think we've got that wrong, sorry, could have gone backwards. This is the over 10 centimetres, where the curves seem to show some divergence, and the mature data again appears to show some divergence, but they appear to be coming together. Now, the early data from overall survival showed that there was no difference. The lines basically overlap, and the more mature data showed that lines overlap. And what this study really showed was that if you gave Imtinib for 12 months, you could delay, or you appeared to delay, the recurrence of GIST that were going to recur, but you did not stop it recurring, and patients weren't living any longer. And there were a number of criticisms of this. Were they really a high-risk population? It was quite a mismatch of patients. Is 1 year sufficient? And there's a lot of debate among the surgeons in the UK and the bigger centres that these patients were treated in small centres, a lot of different centres, and there was a question mark how good the surgery was. And if the amount also included tumour rupture and multifocal disease, which actually I've been giving Imtinib to patients who've ruptured their tumours at surgery since it came out, really, because we know these patients are very high risk and probably shouldn't be included in adjuvant trials. And we also know some French data. So the French had a number of trials where they stopped Imtinib in patients with advanced disease. And they did it after 1 year. And what happened was the progression-free survival and the overall survival. So what happened was when patients stopped Imtinib, at about 6 months, they started to recur, but you could be salvaged by going back on Imtinib. And so they moved to 3 years Imtinib, and again, once you stopped Imtinib, the tumour came back, but again, you were salvaged by going back on Imtinib. So the question is, if you have do you need adjuvant treatment when you've got a very effective salvage treatment. Or if you're not stopping the GIST coming back, you can avoid having imatinib if you don't need it, and when the GIST does come back, you start on imatinib. And this was suggested by the French data in advanced disease, and that mirrored the Z9001. And it didn't matter, and that's been updated now to 5 years as well, it didn't matter if you took imatinib for 1 year, 3 years, or 5 years, it was still about 6 months after stopping it, then that's when the disease started to come back again. So we've now got, and that was the data we had in 2009. And then there was the Scandinavian group, which they looked at tumours over 10 centimetres with a high mitotic rate, or over 5 and 5 of both tumour spirocytic mets. And they gave imatinib 400 for a year, or 400 for 3 years. And then there's the second study, is the EORTC, which gave imatinib versus placebo for 2 years. 900 patients randomized. So after 2009, in 2010, before the data of the Scandinavian trial came out, we took a proposal to NICE for adjuvant imatinib, and it was turned down. So in the UK, in 2010, you could not have adjuvant imatinib. So this is the Scandinavian study. There's approximately 400 patients, randomized 200 to each group for imatinib for 1 year, 12 months, or for 36 months. And then again, they did include patients who had had tumour rupture and multiple sites of disease, but these were excluded. So they had the overall intention to treat population, but they also had what they called the efficacy population, which were those patients who had GIST confirmed at a major centre, at a reference centre. They did not have metastases at study, and they did not have tumour spillage. Don't worry about this, other than you won't see it at the back, but this is the number of the patients. About 90% were considered high risk by modern criteria. So this was a very different population. And this is the intention to treat graphs. So on the left, you've got the recurrence-free survival, 36 months versus 12 months. And this is the efficacy population. So when you took out the patients who they didn't really want in, and again, you can see there is a delay, or there appears to be a delay, and the curves haven't come together. So there's a delay in the GIST coming back in this study, up to 6 years. And if you look at the overall survival, there was a survival benefit in terms of 3 years over 1 year. So this wasn't placebo-controlled, so we didn't have a no imatinib arm, but it actually showed that you could improve survival by giving imatinib for 3 years versus 1 year. And recurrence-free survival was 48% versus 66%. The p-value is a statistical measure to say, was this by chance? Less than 0.05 is thought to be a good and statistical level. So this is highly statistically significant. This couldn't occur by chance. And likewise, the overall survival was 82% versus 92%. And this was the first study that suggested survival benefit for adjuvant imatinib. And the Cancer Drugs Fund, which is in the news all the time, and apparently is going to go for a few more years. NICE still haven't they appraised it, but that we can now get adjuvant imatinib for patients with high-risk GIST following surgery, funded through the Cancer Drugs Fund. So it's got to be high risk, completely resected, and we can give treatment for 36 months. So what about the EORTC 62024? This was a placebo-controlled, so this was going to really show you whether imatinib was better than not having imatinib, although the Scandinavian study suggests that the longer you have it, so if you don't have any, probably the more you have, the better. And the primary endpoint, as it should be in any adjuvant study, was overall survival. But unfortunately, there weren't enough events in order to, the data has never been published yet. And they changed the endpoint a few years ago to what they call the time to Imtinib failure, or the Imtinib failure-free survival. So the argument is that you have Imtinib for 2 years, you then stop Imtinib, and then if the GIST comes back, you start Imtinib, and you take it until you get Imtinib failure. Or, in the placebo arm, you don't have Imtinib, maybe your GIST comes back a bit sooner, but you start Imtinib, and then you stay on it until you get Imtinib failure. So the question is, and that's thought to be a surrogate for overall survival. So it's the same point. So whether you can get, whether if you have a year or 2 years in this case, then some time off and then start, do you get the same duration when you start again as if you have nothing, you start a bit earlier? So maybe if you've had it for 2 years, you have a year off, then you start it again, you get 2 years benefit. So you've got 5 years. Or maybe if you don't have it, you have 2 years off, then you start and you take it for 3 years and you still get 5 years. And so trying to answer the question is, can you salvage patients very effectively by giving it when they need it? And hence, can you avoid adjuvant therapy? And again, it was published, the immature data was published last year, and the recurrence-free survival seemed to be better, but we know that from all the other data. However, the 5-year survival, or the failure to the Imtinib failure survival, 87 versus 84, was not statistically significant. So on the current data, this study is not showing a survival benefit for adjuvant Imtinib. It was a 5-year survival was 100% versus 99%, which is fairly reassuring. Against that, I always say to patients, or often say to patients, you've got to weigh up what you're going to benefit and what you're going to lose. And if I can give you a tablet you're going to take for 5 years that has absolutely no side effects, and it might work and it might not, it's a very small chance you'll take it. If I give you a very toxic treatment, you need to know there's a big gain, otherwise you're not going to take it. And interestingly, what we see in a lot of adjuvant studies, and is some really counterintuitive, that when we give chemotherapy to patients with advanced disease who are ill, they cope with it better than when you give it to patients with adjuvant who are basically fit and well, and they cover them surgery. And the theory is that if you've got advanced cancer and the chemotherapy is working and it's helping, you feel better and you carry on with it. If you're completely well and you're taking some treatment that makes you feel less well, you're less inclined to carry on with it. And we've seen that in lots of studies. This was just some data from many years ago. We had a lot more patients now. A lot of you will know the side effects better than I will. This was the Z9000, the early phase 2 data. 18% grade 3 toxicity. That's toxicity that's significantly affecting quality of life. So grade 1, few symptoms. Grade 2, it's starting to affect you. You've got grade 3 toxicity. It's significantly affecting your day-to-day living. That's almost 1 in 5 patients. That's a very busy slide. Now, interestingly, as every placebo-controlled trial shows, placebo in green and Imtinib in orange. So actually, for mild toxicity, taking placebo is worse than taking Imtinib. And placebo trials persistently and consistently show a significant number of toxicities. But clearly, once you get to the serious, which is severe effect on life, and life-threatening in 4, clearly Imtinib is potentially a toxic drug. So, which patient should we give it to? So from early on, we knew there were 2 significant prognostic factors. 1, we knew size was very important, and 2, we knew that mitotic index was important. And the initial prognostic scores were based on size and mitotic index. But we also now know that depending on where your tumour starts, in which part of the GI tract, that is also a significant prognostic factor. And of course, we now know where your mutation is also can be prognostic, but more importantly, perhaps, it determines how you're likely to respond to Imtinib. And basically, I hope I get this right, and Philippe will tell me if I get it wrong, but he's not here, so that's okay. Exon 11 mutations are here, just inside the membrane. Like this is an American slide, so in America, Gleevec is Gleevec with a double E, blocks here. And so this is the mutation, this is the site on the ligand blocked by Imtinib, and that's the classic exon 11 mutation. Other mutations on different parts of that ligand are less likely to be blocked by Imtinib. So as I say, this was the initial Fletcher classification in 2002 based on size and mitotic index. I don't know about this. And this was the Mutation where they looked at size, index, and also site of disease. Don't worry about that. This is a slide I used before. And then there was the modified classification, the patient that should be considered for adjuvant Imtinib, over 5 centimetres and over 5 mitoses per 50 high power fields, over 10 centimetre in any mitotic count, any size, and over 10 mitoses per 50 high power field. And then there were some other groups. So we know that gastric tumours generally do better than non-gastric tumours. And again, tumour rupture, I think a lot of us still believe that that's not truly adjuvant, and if you had a ruptured tumour, as I say, I put people on Imtinib indefinitely. And not exon 9. So the question is, and that comes back to the question earlier, should all patients get adjuvant Imtinib, whatever their mutation? So using these selection criteria, about a third of patients with a gastric GIST would be considered, about 2/3 of non-gastric GISTs, and 50% of all GISTs. So overall, that works out for the whole population about 50. Now, interestingly, and I think I've lost a slide somewhere, when you looked at the Scandinavian study, they looked at the different subgroups, and there was a benefit for each type of exon mutation, which we wouldn't have thought. So we would think that 9s and wild types would not benefit. Now, that was a very small subgroup analysis, and there were very small numbers of patients, but there was a consistent benefit, whatever the mutation. So what answers do we know? These are perhaps now the known knowns. Will treatment prevent or just delay the recurrence? Well, we're still not entirely sure. The Scandinavian data appears to show a survival benefit, but will the curves eventually come together? So at 10 years, maybe the curves will come together. But of course, if you can stop people dying for a lot longer, that is still a benefit. So the question is, is there any chance of Imtinib curing patients? And we just don't know the answer to that. But it certainly seems to make people live longer in the adjuvant setting in the Scandinavian study, but it hasn't been confirmed in the EORTC study. What is the optimal length of time? Well, we know that 3 years appears to be better than 1 year, and that's all we know in length of time. You know, maybe 5 years better than 3 years, maybe indefinitely. Maybe you should start Imtinib and then carry on indefinitely. We don't know. And that goes back to what we already discussed. Maybe we can just wait, and okay, your GIST comes back a bit sooner, because Imtinib's never going to stop it coming back. It will delay it coming back. So instead of coming back at 5 years, it comes back at 4 years. Instead of 8 years, it comes back at 6 years, or vice versa. So it may be you get just the same benefit by waiting and starting, and lots of people avoid getting adjuvant treatment who didn't need it. And this was a question we used to ask, that maybe if you're potentially, are you worse off if you have adjuvant treatment? Because do you actually induce, and we know as GIST develop, they develop further mutations, and that's why you sometimes see patients with multiple sites of disease controlled by Imtinib, and then just one site starts to progress. And that's because as the tumour carries on and longer time, it develops secondary mutations which allow it to escape imatinib control. So is it possible that by giving people imatinib early, you can actually increase the rate of mutations? And is it possible you could actually disadvantage them for future imatinib? Now, there's absolutely no data to suggest that, but it was an interesting question. And this comes back again to, are the patients unlikely to benefit? Well, according to the Scandinavian study, even those mutations which are not strictly or considered sensitive did appear to benefit, but numbers very small. And should it be tailored to mutation? So maybe we shouldn't be giving imatinib to everybody. Maybe we should give sunitinib to some people. We just don't know that, and there's no data. So, where do we go in the future? Well, the ERTC will hopefully give us some further data. And this is the slide I always finish on, which is a bit naughty, really. But you know, what will come out in the future? But more to the point, can we afford it? For those who can't see it, so this is one of those new miracle drugs. If you can afford it, it's a miracle. And as they decided we're going to have to keep on reducing the burden on the NHS by 3% per year for the next 5 years, and we've already done it for the last 5 years at 3% per year. Even if you use simple interest, and probably as mathematicians, that turns out to be 30% deduction in 10 years, and actually it's compounded, so it's a lot more than that. So there's going to be an £8 billion gap by 2020. So, you know, what will the future hold? What new drugs will come out? And more importantly, we'll be able to afford them. So that's my take on adjuvant treatment. So I hope it didn't differ too much from what you heard this morning, and I hope it at least answered some of your questions, if not created more than it answered. Thank you.
Thank you very much. I'm sure there'll be quite a lot of questions after that, because the questions that were raised this morning about taking adjuvant imatinib, you may have sort of had a bit of a rethink now. I know when I was offered adjuvant after my liver resection, I decided no, and my consultant was happy with that. We agreed that I wouldn't take it. I'd wait until it came back, if it was going to come back. And I'm 4 years on, I'm happy that I made that decision. I've saved the NHS some money. I haven't had side effects for those 4 years, and it's still there for me if I need it. But I know other people take a very different view and would rather sort of back the horse both ways, as it were. So are there any questions from the floor that people would like to ask?
My husband's coming to the end of 3 years. My husband's coming to the end of 3 years on Glavac after a large tumour has been removed and all the rest of it. So if it comes back in 6 months' time, is that classed as a secondary? And would it have to go on to different treatment?
No, that would be recurrence. Well, it's recurrent disease, but it's not in terms of, it's not an imatinib failure. So is it a secondary? Is it the recurrence of the local site? But I guess the question is, does he need to move on to second-line treatment? And no. So the first line of treatment after imatinib, okay, if you fail adjuvant imatinib and disease comes back while on it, then you'll move on to second-line therapy. If you've stopped it and the disease comes back, then you go back on imatinib. And the French data suggests that by far and away majority of people will respond just as well, indefinitely. So that then becomes the current disease, and you will stay on it until you develop progression on imatinib.
Or have no surgery.
Or if, yes, or potentially you could operate, and if it's a solid recurrence, you may operate when it comes back, or you may downstage, but not allowed to downstage. Nice say no. But then we all have plenty of patients who we really can't quite operate, so we can listen to Imatinib to make it smaller, and lo and behold, we can. So we can always... there's no one very official here, are there? There's nobody official here, is there?
A couple of reps from pharma companies.
That's okay. Nobody from NICE?
No, there's nobody from NICE.
We have been known to slightly bend the rules in patients' favour.
Anybody else got questions about... Oh, sorry.
Just a brief comment. You won't know about non-compliance, will you? Unless some of your patients admit to that. But there is data I've seen from a French group that non-compliance, this is of people who are ill and would normally be expected, was up to 25%. These are people who regularly stopped the treatment and had a break and a rest. I would have thought non-compliance with adjuvant treatment would be higher. Is that a feeling you have? And that the benefits of adjuvant leave it would then be greater than it appears?
Good point. Yeah. Oh, I'm going to get fit. Yeah, we should have had 2 mics.
Maybe I should just follow the microphone. No, it is a good question. We know that there's always non-compliance with tablets. You know, people get a week's supply of antibiotics and they feel better in 2 days and they stop and they haven't sorted out the infection. Now, a good study, the patient should bring the remaining tablets back. So you count out the tablets. Now, of course, the savvy patient will realise they're being checked and just flush them down the toilets or leave them at home. I think the question is if you're non-compliant and you don't take them for a couple of days, does that matter? So because of the way Imatinib works, and we know that if you stop it, it takes 6 months, if every few weeks you don't take it for a couple of days, does that matter? It probably doesn't. But we haven't got the data. There's no data on that. But you're right, generally people don't take tablets.
We listened to Ramesh this morning, people who were on a higher drug, I think it was Sunitinib, if they came on and off, that was much worse than going on a lower dose and continuing. So it would suggest that maybe coming off was not a good thing.
But that's, yes, Sunitinib was started at too high a dose. And although according to NICE, and again, it's one of those things we just don't follow the rules, allegedly. Some other people don't anyway, obviously I do. So 50 mg per day is toxic, and you cannot carry on that. And there's evidence in kidney cancer and for neuroendocrine tumours, the starting dose is 37.5 daily, indefinitely. And a lot of the time I'll start patients on 37.5, and it's better tolerated. But that's because, now whether it's better, it may be more effective, but that's 4 weeks on, 2 weeks off. That's very different to missing a few doses. But you can't take that dose of Sunitinib indefinitely. No. But I don't know the answer. Sorry. Shall I just walk over with it? That'll be easier. Thanks. I know my place. Patients always come first, don't they?
2 questions. Can you clarify where we are, as far as you know it, with the NICE committee meeting with reference to it being approved by the NHS for use in the adjuvant setting? And the second question, I can't remember. Oh, yeah.
That one first while you're thinking about
No, I have. Is memory loss a side effect? That's a serious question.
Yes, it's a bit like how many people are going to get diagnosed with dementia now. In the next 6 months, there'll be so many people diagnosed with dementia now, the GPs get £55 for every diagnosis. I'll answer your second question first, not as far as I know. But then I've actually forgotten. I was going to say I've forgotten your first question. That was genuine, but now I remembered. No, that was not a joke. That unfortunately was genuine. I saw Ian Judson last week, who a lot of you will know. And it's going back to NICE. Now, I was part of the Birmingham group. It's the university put together the submission for NICE. And I can probably tell you, but don't tell anybody I told you this. it was put to NICE as 3 years, and there was no data on 3 years. And is anybody here from the company? Because the problem was they took the 12-month data and extrapolated it to the same survival benefit and the occurrence year on year on year, and you just can't do that. So actually, I went to the NICE meeting and they were very sympathetic, and I think if it had gone for 12 months, they would have accepted it. So based on the current data of 3 years, the new data, we're optimistic that it will be accepted. Now, in some ways, it doesn't matter too much because it's funded through the CDF, which is ongoing, and I don't think any of us see there'll be any major change. So it is funded through the NHS. It's just whether it's NICE approved through the commissioning groups or whether it's funded through the CDF. But Ian was optimistic that it would get the nod through NICE.
I was at the meeting and I'm also optimistic.
Yeah.
In fact, I was reasonably sure it had already.
Not as far as I know.
I asked Gwen because you raised it in your...
I don't know if anybody else knows better. I saw Ian last 10 days ago, and it hadn't been announced, certainly.
Ramesh seemed to suggest it had.
Well, perhaps he's got some inside information.
Well, as I say, I get all the... Because I'm on the top secret panel.
Well, you should know.
But yeah, but it's not. It was nearly there. I just wondered if you knew if it actually had been rubber stamped.
I'm not as high up in the top secret panel as you, I don't think.
No, I didn't know. I couldn't know.
No. Far down the pecking order, sorry. Oh, dear me, I have to walk about. Yeah. Oh, I think I'll just leave.
No. You're okay. I wasn't personally involved in it, but I was trying to work out whether you were talking about Gleevec or not. It
was 2010 when we put in the bid.
Yeah, so it's the adjuvant,
adjuvant
use of Imtinib. The final appraisal determination has been made public on their website, and it is as was in the ACD. So, as was suggested in the ACD, is now also in the FAD, and that is it's still. I think there may be. And the answer is 3 years.
So it's been approved through NICE.
Yes.
Right.
Yes.
I'll check my facts before I do another talk. Thank you.
You're welcome.
There's a lady who can't even get there. I'm sure this isn't part of my job to walk down with the microphone.
My question is about generic Gleevec, because in my situation, I won't wait until my yeast come back. I have removed my rectum and I have colostomy, and really this was traumatic time in my life. And really I like to carry on Gleevec. I know that NHS just can guarantee me 3 years. Do you have some information about generic Gleevec, how I can?
I have no idea, but I know a lady who might be able to tell you some information about that.
Can you repeat the question?
I think the question is, so we get Gleevec that's very expensive, and will there be generic Imtinib that will be much cheaper? And when does your patent fall off? And will anybody else make it, or is it just too expensive?
So we know this much, that people have put forward, or companies have put forward, for generic. We have a complete patent for the product till the end of 2016, and there's a GIST patent, a sort of for the GIST specific indication that goes thereafter. I think there's a very competitive generics market in the UK, and I think it probably goes without saying that generics will come onto the market and they'll be very competitive. And beyond that, at this point, yeah, but of course, and amongst the generics companies, there'll be competition.
Perhaps I should give you a less biased opinion. Now, it won't be generic, will it? Because it's a biological agent. And so, and I can't remember the correct term. So if it's a standard, if it's a antibiotic, or if it's a, for example, omeprazole, a antacid, you now have a lot of azoles, and they just make, and then they're all made very similar, and then as soon as they come off patent, anybody can make exactly the same drug to the same, and just use it, because it's exactly the same chemical compound. Now, for biologicals, it's not quite the same, and I can't remember the exact term, but they're not called generics. Thank you. Biosimilars. Do you want to answer the question? So biosimilars have to go through a much more stringent assessment, and they have to go through a number of the clinical trials. Now, they don't go through all the phase 1, phase 2. And the argument is that if you make a biological agent, such as an IB, the way you make it, it isn't simply a chemical structure. It has to go through a lot of processes. It may be produced by a cell line. Now, we know that some cell lines for certain agents over the years in certain companies have changed, and officially they should then take that next batch of drug and check it against the first batch, because the cell line is different. So if you have a biological being made by a different company, it can't just come onto the market the day the patent runs out, unless they've done all the work beforehand. I say it doesn't have to go back through all the early phase 1, phase 2, but there's to be a number of studies where it's compared to the standard drug. So the answer is, at the moment, there's no generics out there, or no biosimilars out there, to be precise. But it is likely, it's a big market in Imtinib. I can't remember how much it was. At one time, it was the second or third biggest selling cancer drug in the UK. Yeah. It got overtaken by bevacizumab for bowel cancer and Septin. But of course, a lot of it, the big market's also leukemia. So there'll be a huge market for biosimilars. But at the moment, you can't buy them, sorry, because they aren't there. But there was some big thing where you could go to India and buy Imtinib, couldn't you? Very, very cheap. But it was that was being made, wasn't it? That wasn't a genuine article.
I can't answer on that, honestly. I don't know.
No, I mean, it was in the paper. It wasn't inside information.
Is it? I mean, it's not a very big molecule. It's not like... Isn't it synthesized? It is synthesized. Is it a biological process?
I think a nib.
About 25 atoms.
It's a small molecule.
Maybe it's...
It's a complex. Put it this way, it's a complex.
I guess the companies, I guess one side will argue it needs to be tested, and the other side will say no, it's exactly the same. I think it's where it'll fall between the two, no doubt.
You can buy it from India by the kilogram, not pills.
I was hoping for some easier questions.
Thank you. I've been on Imtinib for 10 years. I'm still here, but at various times, 800 has been thought important. Obviously, NICE isn't allowing that, I understand. Should we be pushing for that to be allowed? I know I took it once. The side effects were quite severe or more severe, but it definitely worked.
No, you're right. There's very good data on dose increasing, and at one time we could get it through the company. So before Scandinavian got a license, compassionate use, they would give us 400 extra. So patients were being dose escalated. Once Scandinavian got licensed, and NICE said no to dose escalation, just because we had to, we changed Scandinavian. But the data from the early studies, the majority of patients don't benefit from, if you look at the original data, the benefit of 600 or 800 was small compared to 400, and as you say, it's a lot more toxic. But we do know that if you progress on 400, there's a good chance of responding to 800, and wild type and perhaps Exon 9s in the sub-analysis, they did benefit. So there are groups of patients who do benefit, and NICE have got it wrong.
Can clinicians fight to the Cancer Drugs Fund to get Dextra?
You can, but you've got to show exceptionality. And the way to show exceptionality is virtually impossible, because every patient's exceptional, but they just say that, you can't argue it, because you can't, the rules are so tight. So you know the answer.
No. Another question. For those of us who have been on, and there's somebody spoke earlier who's just about to come off 3 years of Imtinib, I've just come off it. How long does it take? My experience was when I came off it, for the first 4 weeks, I felt one hell of a lot worse than I was when I was on it. And I've only recently started to feel a bit better. I had terrible headaches and all sorts of other minor problems that were worse than when I was on it. Is that normal? And what is the length of time? My oncologist said it is normal, but the length of time is difficult to predict. It's different in everybody. Is that your experience as well?
Another question I don't know the answer to, because most patients, historically, when you stopped it, because they either had side effects, and therefore they got better when they stopped it, or they had recurrent disease, unprogressive disease, and therefore went on something more toxic. So we're only going to start now seeing a cohort of patients who have been well and on it, stopping it. Now, I don't know why you should feel worse when you stop it. Maybe it's anxiety.
I was told the phrase cold turkey. You've been on a drug that's toxicated your body for a long period of time. You come off it and...
But you only get cold turkey if it's had some sort of positive physiological effect. So what are you withdrawing? I don't know. I don't know.
All I know is I felt pretty rough.
Does anybody else have a similar experience?
We're not coming off it.
I can't say that that's definitely what it was, but I have been experiencing headaches. And there's also been a slight change in my blood pressure.
I've got to say, my experience has been patients, particularly on Adjuvant, who have stopped it because they feel awful. And then they come back 2 weeks later and feel so much better. And we start on 300, no data, but we know that some people don't need as big a dose. And they either tolerate or they stop it, they get side effects again, and we stop it again, they feel so much better. So, I don't know, sorry.
It was just a comment. I was taking it for 3 years and 1 month, and I felt exactly the same when I came off it as while I was on it.
Right.
So I've had no withdrawal symptoms.
I mean, I just don't understand. I mean, I don't know why, but there may be a reason why you get cold turkey. So.
Wondering if you've ever had examples.
You have to use the microphone.
Oh, have you ever had an example of people using Imtinib, then getting progression of disease, going on to sunitinib, finding it didn't suit them and having to stop, and then you suggesting they go back on Imtinib again, and then they respond to Imtinib again, and it works again?
There is some data on the challenging with Imtinib. But again, we'd have to sort of bend the rules a bit, or quite a lot.
Is that what's called downstaging? Is that what you mean by that?
No, downstaging. So NICE say, if you've got operable disease, then you have an operation. If you haven't, you have Imtinib. Now, the question is, if you've got, and they've actually said you shouldn't give neoadjuvant. So neoadjuvant is when you have a big tumour, you can't operate. So what you do is you give 6 months, 9 months, and you make the cancer smaller. Now, technically, we're not supposed to do that, but officially. But if you have a patient with a big inoperable tumour, and they respond very well, 6 months down the line, you don't say, ooh, I'm not allowed to take it out now, am I? So we do it. And these patients then always go on to the adjuvant as well, because I had 1 or 2 patients, and we ummed and ahed in the early days, and we stopped it, and they've got the recurrence within about six months. And so now anyone who's had a tumour big enough or bad enough to require neoadjuvant automatically will go on to adjuvant. Although interestingly, I've got 1 patient who had Imtinib and didn't tolerate it, had sunitinib and didn't tolerate it, and over the next few years, having stopped everything, and it's just they suddenly started getting smaller, and he's actually had, and I can't explain it. He stopped everything because of toxicity, and his tumour has got smaller and smaller. And we scan him, and we take him to the MDM, and we discuss it, and we check we haven't got the scans mixed up. But I've never seen that before.
When you resect that tumour, Jane definitely wants a sample.
Well, we can't dissect it, and we're not going to now because it's got better.
Can you biopsy it?
I think we just accept it.
Right. Oh, sorry.
Yeah, I just wonder if there's much data on this drug, regorafenib. Is there anything much to show that that's going to be a drug of the future?
I can't even say it. We don't know. I mean, the other drug that came along was nilotinib, which was the sister of imatinib, and it may have had a place. Some patients did well on it, but all the trials have been stopped because the data. I mean, there's a lot of new IBs coming along, and I think it's finding the place for each one, and whether, as we learn more, we'll know that certain deletions or mutations, it's better to have one or the other. The other question is a combination. Should you have combination IBs? Do you do better by having upfront? I mean, chemotherapy now, it's very unusual to get single-agent chemotherapy, so we know you get a benefit from putting two together, working slightly different ways, and that might be the future for GIST. I've taken the slide down because I thought it was a bit naughty, especially now I know there's some people here who wouldn't want to see that. But, but against the cost. I mean, you're going to pay £2,000 a month. What benefit what benefit would NICE have to see to pay £4,000 a month rather than £2,000 a month? But it is available on the Cancer Drugs Fund as well.
So the Cancer Drugs Fund isn't finishing. I read an article in the paper that it was going to be,
They've agreed funding to 2017. But can you see any political party saying, oh yes, we were giving £200 million a year for cancer drugs and we're going to stop it? I mean, it was a big con, of course, because they took it in other parts of the NHS. It was not £200,000, the £200 million they gave, 200,000, that'd be good, wouldn't it? Yeah, they were giving £200 million for cancer drugs. It went from other places.
Right. Any more questions? It's been really, really interesting, and I think we owe Dr. Peake a huge vote of thanks for his time and his patience.